Now, whereas autonomic nervous system and neurotransmitters and receptors may be really new information for a lot of you, this chapter is probably going to be one that you are more familiar with than others. And so this chapter is really about the circulatory system. And when we look at the circulatory system, we're going to see that, of course, we realize it's for transportation, our respiratory transportation of oxygen and CO2, nutrients, waste products. But it's also for regulation, transmitting hormones around the body. But your circulatory system also helps you with temperature regulation. And as football season gets closer, I love the old NFL films, historical documents of the frozen tundra of Lambeau Field, when the players take off their helmets and you see the heat radiating off their heads. That's because the blood vessels have dilated to allow the heat to radiate out of that area. Your wrists are another place where you can get a lot of that radiative heat. And in fact, if you are too hot on a summer day, don't pour water on someone's head. They might go into shock. But slowly run water over your wrist, because look at all the superficial vessels right there in your wrist. That's where you can exchange a lot of heat. And if you run cold water over it, that exchange is going to be even more rapid. But we're also in circulatory system going to talk about protection. This is where we find many of the components of our immune system, and the circulatory system is the highway that immune cells can transport themselves around your body. But the clotting systems that are in place are for your protection from losing too much blood. So there's some built-in mechanisms that help to prevent the loss of blood. Now in this illustration, we can see our arterial system and we can see our venous system. Now, arteries by definition. Give me a definition of an artery. That's going to work for every artery in your body. This is the kind of tricky one. Arteries transport blood away from the heart. You almost instinctively want to go for the red, full of oxygen. But your pulmonary arteries are absolutely devoid of oxygen. Likewise, the venous system, vessels that transport to the heart. Your pulmonary veins that are going from the lungs back to the heart, they have the richest amount of oxygen in the body. So that oxygenation rule applies to most of the vessels, but the directionality, that's what applies to all. We're going to start looking at blood as part of our circulatory system. The liquid portion, the cellular portion, the portion that's fragments of cells, and the proteins. And so we see that in an average adult, the volume of blood in the human body is going to be around 5 liters. Now what's interesting is we look at various criteria in the human body. This 5 liter mark, we're going to see that a lot of things are right around this 5 liter number. I don't know why that's necessarily the magic number, but 5 liters is going to be important. Our osmolality, or osmolarity of our blood, right around that 300 milliosmol mark, when we talked about hypotonic and hypertonic. And then the pH of the blood is going to hover around 7.4, slightly on the alkaline side of absolute neutral, which is 7. So we refer to 7.4 as physiologically neutral relative to our bodies. Now, when we look at the components of blood, we're going to see that 45% of the volume of your blood is in what is called formed elements. You're going to instinctively want to refer to these as your blood cells. But when we get to platelets, we're going to see they're cellular fragments. They're not, in fact, cells. So that's why someone came up with the term formed elements. Your formed elements are going to mostly be your erythrocytes, your red blood cells, because they outnumber your white blood cells 1,000 to 1. So the percentage of the volume of your blood that's white blood cells is really insignificant compared to your red blood cells. Your white blood cells are referred to as leukocytes, and then these small cellular fragments are your platelets. They're going to really be responsible for a portion of our clotting cascade. The other 55% of the volume of our blood is the liquid portion of the plasma. Predominantly water, but we've got a lot of other important acellular material that's present in your plasma that plays a tremendous role in your physiology and your homeostasis. Here's my big information slide, right? We've got the formed elements on the left, plasma on the right. We see our platelets, red blood cells. See, your red blood cells are 95.1% of the formed elements. Platelets almost 5%, and your white blood cells barely 0.1%. Now, this would be in a normal, healthy individual. If you're ill, those white blood cells are going to rapidly increase in number, and that would change the percentages. In our plasma, 92% water. We also have the electrolytes, our ions, wastes, nutrients, gases, O2, CO2. But notice a big part of our plasma is going to be proteins. The proteins in your plasma are going to be critical for the functioning of the human body. Now, a really nice measure of your body's health, fitness, and your body's ability to transport oxygen is going to be examining what percentage of your blood volume consists of red blood cells. And we refer to this as the hematocrit. And your hematocrit will either be a percent of cells per volume or an amount of hemoglobin. If you go to the blood center these days, they're measuring your hemoglobin and basically extrapolating your hematocrit or your percent red blood cells. Now, in males, normal hematocrit ranges from 41 to 55% of your blood. Females, 36 to 46%. Again, we're getting into that generalization based on muscle mass. If you're a male with a lower muscle mass, your hematocrit's going to be lower. If you're a female with greater muscle mass, your hematocrit's going to be higher. The blood serves the muscle. Now, we've probably all heard of anemia. I'm not sure if any of you have experienced anemia, the shortness of breath when climbing stairs, but that's because you either have insufficient hemoglobin per cell, or you may have a normal amount of hemoglobin per red blood cell, you just don't have very many red blood cells. And so if your hematocrit is lower than 39% in males and 36% in females, you're considered to be anemic. And we also show the grams per deciliter of hemoglobin, which is the oxygen binding and transporting molecule of red blood cells. If we start getting down into the neighborhood of 8 to 9 grams of hemoglobin, now we're getting into severe anemia. You're likely going to experience symptoms and likely going to be treated at levels much higher than these, but this is pretty severe anemia. It might be caused by diet, maybe by disease. There may be some genetic predisposition for that. But docs are going to check that fairly closely. I think almost any blood test is going to involve a hematocrit when you go to the doc. Sometimes we can have anemia. I mentioned because of diet. So if you have a diet that is lacking vitamin B12, then vitamin B12 is often used, it is used to produce new red blood cells. And so you're not going to produce as many red blood cells, so the blood cells are going to die, and you're not going to be replacing them because red blood cells live for 120-day average. And so you're going to be anemic. And so if you're not getting enough B12 in your diet and you're anemic, that's referred to as pernicious anemia. That's an easy fix. You just get more B12. However, your stomach produces and secretes a protein called intrinsic factor, which is essential for the absorption of B12 from your gastrointestinal tract into the bloodstream. So if you're not getting enough B12 or you're not producing enough intrinsic factor, both could lead to pernicious anemia. And you may in fact see some patients these days, it's becoming more and more common, in which they may get enough B12 in their diet, but they're not producing enough intrinsic factor because of an elective surgery that they've had. What elective surgery could someone have had that's going to reduce their body's ability to produce intrinsic factor? Remember, it's produced in the stomach. Gastric surgery. I think bypasses leave the tissue, they simply go around it. The sleeve procedure, I think, is one. Lap band just causes the stomach to be compressed so you can't hold the volume of food. What the sleeve procedure, your stomach, the esophagus comes down, the duodenum extends away, and the stomach curves around. The sleeve basically cuts off the curve of the stomach and makes your stomach just a tube, a sleeve, so it can never really hold much at one time. You can't overeat. But when you remove that much gastric tissue, you're removing the glandular portion that produces intrinsic factor. Boom, you automatically have pernicious anemia. Now, here's the other thing about B12. B12, if you've got a lack of intrinsic factor, is it going to do you any good to take a B12 shot? I mean, to a supplement, a pill. No, because it's going in your stomach. Shots are said to be the best way to get B12 into your system, especially in intermuscular, because you've got a lot of blood vessels around the muscles, and it can be absorbed directly into the bloodstream. The second best way are the sublingual little tablets, because again, there's a high concentration of capillaries in your oral mucosa, and that way it can be absorbed directly into the bloodstream. But swallowing a B12 tablet is not going to be good to help those people. They're going to have other sources and applications of the B12. Now, the opposite of anemia, having too few red blood cells, is polycythemia, having too many. And you may think, well, too many red blood cells, too much oxygen, how's that going to be a bad thing? If you have too few, you're going to get short of breath. But it would stand to reason if you had more, you would have more stamina and more endurance. And a lot of athletes are going to try to do this and find ways around doing this. We'll talk about in a minute. But why would it be a bad thing to have too many red blood cells? Can anybody think of any logical reason why that would be bad? Too much oxygen, fainting, probably not. Now, you're probably going to have to get way higher than what we could physiologically do here on Earth, because in the atmosphere, we only have about 21% oxygen anyway. All right, so you're only going to saturate the cells to a certain extent. So probably not that one.
Would you end up getting, like, if you get too many red blood cells, does that drop your count of, like, white blood cells and everything you have in your blood?
Doesn't change those percentages. Doesn't change those percentages. White blood cells, platelets will still be the same percentage. Let me ask it to you this way. How many of you like iced tea? Hang on, I'm getting there. Iced tea, okay. Here in the South, I was raised on sweet tea. Are we good with sweet tea? You all know the best place to get sweet tea, right? Who makes the best sweet tea?
A lot of people like going to
Chicken Express. You get that gallon jug of the sweetest sweet tea. My grandmother, Mama, she would boil the tea, and then she would add the sugar to the boiled hot tea to super saturate. There was so much sugar in it that when you would pour it, it was almost like pouring syrup. What did all that sugar do to the tea? It made it thick. It made it viscous. So the more cells you have in your blood, the thicker your blood is, the more difficult it is to move through your body. Your heart's going to work harder. And what is your blood pressure going to do? It's going to jack up. Plus, now you got so many cells, you're on the risk of getting a blockage, a clot, just the cells clumping up and not being able to get through. Because which are the vessels that allow for exchange in the body? Do you remember those? Capillaries. Capillaries are the diameter of a red blood cell. So red blood cells move through the capillary single file, like stacked pennies. It's called the rouleau formation. And if you've got so many in there and they can't get through, they're just going to clog up. So that's a bad thing. And that's our polycythemia. This illustration shows normal blood, 45% hematocrit on the right. When you do a peripheral blood smear, that's what it looks like. Our little donuts, those are our red blood cells. The darker stained cells are our leukocytes. You can see on the left how many more red blood cells we have. And in this patient, we do have a few more white blood cells, but that's just coincidental. We have that. Not a good thing. Now, we're going to touch on the white blood cells just a little bit at the end of this chapter, right before we get into our immune system, since they play such an important and large role in that. And we're going to talk much, much more about red blood cells, their structure, their function, their components. But now we're going to look at plasma first. Plasma, the liquid portion of the blood, a lot of people don't pay a lot of attention to the plasma. But in fact, we're going to see it's absolutely critical. And the proteins in the plasma are even less thought about. Now, probably the most abundant protein in your plasma is going to be human plasma albumin. You ever heard of albumin before? Egg whites. It's albumin. And essentially, albumin in your blood is going to work as stuff. You know that really fancy specific term we use in science? Stuff. And when we were talking about hypertonic, hypotonic, isotonic, what other S word did we use instead of stuff? Solutes. So in your blood, albumin is present to act as a solute, to help maintain the osmotic balance of your blood when compared to the outside of the blood vessel. So that's a principal function of albumin. But albumin also is going to function as a carrier protein. There are various materials, waste products, essential proteins in your body that are not water soluble. You don't want these things floating around in your body. Fats, triglycerides. You don't want that just clumping up in your blood, because oil and water, in this case fat and water, doesn't mix. So one way that your body transports these materials is it makes a sphere of the material. One of them we're going to see is a breakdown product of hemoglobin called bilirubin. You make a sphere of this water-insoluble bilirubin, and you cover that sphere with albumin. Now, when you've got this sphere of albumin, albumin being water-soluble, floating through your blood, is there any issue? No. It doesn't matter what's on the inside because it's not in contact with the water. So that's how albumin works as a carrier, a water-soluble packaging within which the inside of the package can be transported from place to place in the body, even if it is water insoluble. Second major category of proteins in plasma are the globulins. And these are often labeled alphas and betas. Some of these can work as carriers, but the principal globulin fraction that you may have heard of the most are the gamma class of globulins. Gamma globulins, and another term for gamma globulins, are antibodies. That proteinaceous part of our immune system that can bind pathogens and then help recognize and activate our immune cells. So you have a lot of these antibodies floating in the plasma fraction of your blood. Now, the third group of proteins that are critical, and I simply have one of them listed, fibrinogen. These are your clotting proteins. And if your blood happens to leak out of a vessel How long do you really want a clotting cascade to begin? How long do you want it to take before you can form a clot? You want it to happen pretty fast. So the best way to ensure that you're going to have clotting factors present anywhere in the circulatory system where there may be an injury, you're going to fill that circulatory system with the clotting proteins. They're always going to be there. And so fibrinogen is going to be one of the final proteins in this cascade that when you activate fibrinogen, you're going to form this sticky spider web of proteins that's going to stick everything together, and that's going to be the dam that's going to prevent the leaking of the blood, or at least minimize it drastically. So back to our red blood cells now. We've already said erythrocytes. We've already said that, what is our volume of blood, that magic number? 5 liters of blood in the average human. Well, when we look at our red blood cells, 1 cc, 1 milliliter of your blood is going to contain in the neighborhood of 5 times 10 to the 6th red blood cells. That's a lot of red blood cells. Now, take that 5 times 10 to the 6th, 1 milliliter times 5 liters. That's a lot of zeros. That's a lot of red blood cells. And in fact, to help you appreciate that number, every second of your life, 2.5 million red blood cells are produced. And to maintain your hematocrit, that also means that every second, 2.5 million old red blood cells are what? Dying and destroyed and removed from your circulatory system. Because that lifespan, again, on average is about 120 days. I mean, there are cells, especially cells of your immune system we're going to see, some cells may be with you your entire life. Some cells are only going to be around for a few days. Red blood cells are 120 days. And one of the principal reasons that your red blood cells don't hang around longer is they don't have a nucleus. Through the developmental pathway of your red blood cells, and we can see in this illustration, you start with cells in your bone marrow, and you have these large nucleated cells, but as they begin to compact themselves, and you see they're turning from blue to red because they're producing more and more hemoglobin, you get to a stage that this cell ejects the nucleus. And after it ejects the nucleus, it uses its actin cytoskeleton to pull in the middle portion of the cell so we have that biconcave appearance. Now remember, we talked about creating the same distance from the membrane to every single hemoglobin molecule because diffusion is going to be the mechanism that drives oxygen loading and unloading of the hemoglobin. That's why we don't see a round anucleated red blood cell in the human body. So we don't have a nucleus. We have our biconcave appearance. And that's so we can fill the red blood cell with hemoglobin, the oxygen transporting molecule. So 5 times 10 to the 6th per milliliter, right? That's the number of red blood cells per mil, times 5 liters. Now look at hemoglobin. Each red blood cell has 280 million molecules of hemoglobin. So 5 times 10 to the 6th times 5 liters times 280 million. Okay, way more zeros. You got a lot of hemoglobin, right? You got a lot of hemoglobin in your body because every cell in your body needs oxygen. So as we look at hemoglobin is a protein. It's going to consist of 4 globulin chains. And in adult hemoglobin, we have 2 alpha chains and 2 beta chains. And that's represented here in this composite right in the middle where we have hemoglobin. And each one of these globin chains has a centralized domain that is referred to as the heme group. And in the heme group, you have certain amino acids arranged in such a way that they can bind a molecule of iron. And it's actually the iron that is going to bind and transport the oxygen, not the protein. The protein holds the iron holds the oxygen. So we did the math with our red blood cells and hemoglobin, right? Now, times 4, and that's how much oxygen we can transport. Again, just astronomical numbers as far as the body's ability to transport oxygen. "120 days doesn't sound like a long time. Part of the reason, cells don't have a nucleus. The other part is healthy red blood cells that, again, have to squeeze through a capillary that's just about the same size as they are. They have to be flexible. And over the course of those 120 days, these cells become more and more inflexible. I guess just like old people. And so as these cells are moving through capillaries and moving through your organs, they're going to go into the spleen. And one of the functions of the spleen, as well as being a place where you have a lot of white blood cells, it's going to be a place where we have these structures called splenic sinusoids. They're like barrels. Barrels that have small spaces between the wooden planks. And as your blood pressure pushes these red blood cells through those spaces, healthy red blood cells can squeeze through. Old, rigid red blood cells are going to be shredded. And adjacent to these splenic sinusoids, we have a lot of macrophages. We're going to be talking about these cells a lot. These are your phagocytic cells in your body, the vacuum cleaners. They gobble up debris. And macrophages are going to be the first cell that starts the process of converting hemoglobin into a product that you can safely remove from the body. So it's going to be important that they're there. Now, we know people that have lived long lives without a spleen, have an injury, have to have a splenectomy. So in the case of the human body, if you lose your spleen, your liver can take over some of that function of breaking down, destroying, and removing those dead and dying red blood cells, because there are a lot of macrophages in the liver. And in the liver, we call macrophages Kupffer cells, because I guess Dr. Kupffer was the first one to see them in the liver. It's funny how we have these different names. In the skin, we call them dendritic cells, Kupffer cells in the liver. We have this really cool name in the lung. Guess what they're called in the lung? Not by who discovered them, but by something that they eat in your lungs. They're called dust cells. I guess we breed dust. I don't do it on purpose. Dust cells. So you have macrophages all over the body. Here we see our arterial supply coming in with red, our venous system as the blood leaves, and here are these barrel-shaped splenic sinusoids, and you can see the little gaps between the blue cells and the red blood cells squeezing through and all out into the tissue, and they're going to be taken back up into the circulatory system and pass out of the spleen through the venous system. But that's how the cells, healthy cells are cleaned. It's called pitting, as the cells squeeze through. Any debris on their membrane is going to be brushed off, but the old cells are just going to be shredded to pieces. So when you shred a red blood cell, you've got 280 million molecules of hemoglobin per red blood cell that's released. And remember, each molecule of hemoglobin has 4 heme groups. And so as that macrophage begins the process of breaking this down, what's going to happen is the macrophages convert the heme groups into unconjugated bilirubin. Unconjugated bilirubin is not water soluble. So what plasma protein are we going to decorate it with to transport it? Albumin, which is water soluble. So in the spleen, we package it with albumin. We ship it into the blood, and it goes to the liver. And then the liver, the hepatocytes, or liver cells, are going to continue the processing, and they're going to break down this bilirubin that's decorated with albumin. They're going to add glucuronic acid to this bilirubin, and they're going to start to change it. This glucuronic acid is going to make it water soluble. Now, we're processing this in the liver, and so a lot of this material is going to be shipped out to the gallbladder to become a part of the bile. Your bile is going to enter into the first part of your small intestine so you can eliminate it from the body. Some is going to be processed, and some of it's going to make it into the large intestine, and it's going to be metabolized into what's called stercobilin. Now, guess what color stercobilin is? Brown. Stercobilin is the reason you have brown feces. And yet we still have other precursors of this metabolic pathway. Some is going to be urobilinogen. And it's going to get processed, and it's going to be taken up by the kidneys. And when it's excreted in your urine, guess what color urobilinogen is? Yellow. So think about how many times you defecate in your brown feces, how many times you urinate in the yellow urine. That's because you're breaking down 2.5 million red blood cells every, how often? Second. That means you are breaking down, what? 2.5 million times 4. You're breaking down 10 million and releasing 10 million molecules of hemoglobin per red blood per second in your body, and you're having to remove that stuff. Because if bilirubin builds up in your bloodstream, if you're not breaking it down into stercobilin, urobilinogen, bilirubin is going to collect in your bloodstream, and it's going to collect in your tissues. And in that case, you're going to end up with a bright yellow color, and the doctor's going to say, you have jaundice. So this is a very simplistic, looks like hand-drawn diagram, but it's got the information we need. Hemoglobin, release the heme group, conjugated bilirubin happening in the macrophage, goes to the liver where we put on the glucuronic acid, and we eliminate it through our bile. Large intestine, that's the stercobilin. We've got urobilinogen that can make its way into the kidney through the bloodstream, and it's excreted in our urine. So your body's going to get rid of this stuff one way or another. Now that's the protein part, that's the heme part. What about the iron? The iron is bound to the heme group. Macrophages can't eat that. No cell in your body can eat it. But in fact, that free iron is going to be recycled. Now this is usually a question that I get sort of weird looks from students about, but is iron water soluble? If you put a nail in a glass of water, is it ever going to dissolve into solution? No. Iron's not water soluble. So how do you transport iron in the blood? Well, you've got to package it with a water soluble coating. Now we don't use albumin for this. We use a different protein that can bind to iron but is also water soluble. And guess what? Some very creative PhD or postdoc decided to name it. Transferrin. Transporting ferrous material. See how they got the name? So you package it around transferrin, ship it back to the bone marrow. It's taken up by the cells producing red blood cells, and boom, you've recycled it. But you can't recycle 100% of it. And this kind of blows my mind. you lose 1 to 2 milligrams of iron per day from desquamation of epithelium. You know what desquamation is? The flat cells of your skin, some of the flat cells that line your blood vessels, they're said to be squamous shaped, flat, fried egg looking. And so when you desquamate, you shed cells, like when you shed the skin after you get a sunburn or something. But you're shedding your skin cells all the time and making new like a conveyor belt. So just the shedding of your skin and other squamous cells, that's going to account for a 1 to 2 milligrams of iron lost per day. That's astounding to me that you lose that much. So we get about 10 to 20 milligrams of iron a day. I'm not sure if that's the recommended amount or not, but you have to pick up more in your diet. If you get 10 to 12 milligrams, you're going to absorb 1 to 2 milligrams, and that's going to account for what you lose. So you got to have iron. Supplements versus different foods. Don't know the answer to that yet. I'll see if I can find that and talk about that tomorrow when we get back to class. Transferrin picks up the iron in the spleen that was broken down in the splenic sinusoids, transports it back to the bone marrow, where we can begin the process of erythropoiesis. Erythropoiesis means the formation of red blood cells. Hematopoiesis is going to refer to the formation of blood. So we're specifically talking about red blood cells. Erythropoiesis primarily happens in your bone marrow, which is said to be myeloid tissue. Now, during your fetal development, embryonic development, there were a lot of other places that can undergo erythropoiesis, again, including the liver. Liver's pretty talented, pretty flexible. But most of your life, it's going to be in your myeloid tissues. Now, the regulation of your body, we know the central nervous system plays a huge role in regulating your body, but your hormones are equally as important in metabolic regulation. And certainly here, we look at chemical regulators, and especially one that is referred to as erythropoietin. It's kind of interesting. Erythropoietin, it's going to cause you to make more red blood cells. You would think maybe this is pituitary, some other gland associated with the central nervous system. No, where is EPO made? In the kidneys. That's kind of crazy. But when you think about your kidneys, you are going to have a huge volume of blood circulating through the kidney as the kidneys are filtering the blood, filtering the fluid. And so it kind of makes sense. That's a good place to also sort of be aware and account for how many blood cells do we have. So when your hematocrit drops, your cells of the kidney are going to produce more erythropoietin. Put that into the bloodstream. It goes to the bones. Your erythropoietic cells are going to increase their mitotic activity. You're going to produce more red blood cells. Now, are they counting the cells as they come through? No. What these cells are sensitive to are oxygen levels. So if oxygen levels are low, the kidneys say, whoa, we need more red blood cells. We're not getting enough oxygen down here. That's not taking into account whatever's happening in your lungs or happening out in the environment. Because there are going to be areas that you travel to where the oxygen levels may be higher or lower than what you experience under your normal everyday routines, depending on where you live. Athletes have for a long time been trying to take advantage of these things. Because if you have a higher hematocrit, you can transport more oxygen, increases your stamina and endurance. And a big problem that Lance Armstrong and other cyclists, and I'm sure many athletes do this, but cyclists especially, they would blood dope with EPO. Jack up their hematocrit. More speed, more endurance, more stamina. Now, there's another way athletes try to beat the system. Some athletes will do what's called blood packing. Prior to an event, months prior, they will have a unit of blood removed. They may do this once or twice. And then right before the event, they will concentrate the red blood cells, remove a lot of the plasma so you have a smaller unit volume, inject that back into the athlete. What have you just done to the hematocrit? Jacked it up. What's going to be detected on a drug test? Nothing.
So is it illegal to do that, or
How are you going to catch them?
is it just more frowned upon?
It's cheating. I mean, you've medically intervened in that situation, right? Other athletes, what they will do is they will purchase and sleep in a hyperbaric chamber. Now, hyper, above, baric, baro, what is that? Pressure. Are they getting in this thing changing the pressure? Mm-mm. What are they changing in this capsule that they're sleeping in? What are they changing throughout the night? Oxygen levels. So if they sleep in a low oxygen environment, your kidneys are going to sense low oxygen. And what are your kidneys going to make? EPO. What's it going to do to your hematocrit? Jack it up. Is that fair? Should that be allowed? I'm not saying, I'm just asking.
It's an ethics class, but I don't know.
I mean, these days, athletes are as much entertainers as they are true athletes. And I'm like, look, if you're paying them $500 gazillion, let them do whatever they need to do to entertain the folks. You know, and everybody's worried about, oh, who's better than who? I just saw something today. Who's better, LeBron or Michael Jordan? I mean, really? We're even having that discussion? Michael Jordan's head and shoulders. Anyway, no. Did I say that? Sorry. But again, it's a huge problem. And it all stems from having a pretty good understanding of the physiology of our red blood cells. But for those athletes that do the blood packing, man, what are they really running a risk of? Having their cells added back. High blood pressure, polycythemia, strokes, clots. I mean, is it worth how many million?
I'm just saying if they die.
No. I'm saying how many million? You know, but it's driven by money. And they make some pretty foolish choices, all in the name of fame and fortune. So we did red blood cells. We're going to do platelets. White blood cells will be next. And so for our platelets, these are those cellular fragments. They're also called thrombocytes. And like erythropoiesis, the formation of red blood cells, thrombopoiesis, and see, if you didn't link the name thrombocytes to platelets, you wouldn't know exactly what the thromb is. Thrombopoiesis is the generation of platelets. Now, these start, again, in your bone marrow, and cells called megakaryocytes produce platelets. Now, during developments, you have these early precursor cells that are singly nucleated that begin to fuse together with one another until you have this huge, monstrous, multinucleated cell that may have in the neighborhood of 30 or 40 nuclei. It's humongous. And slowly then over time, bits of that megakaryocyte are going to start to pinch off, forming these extracellular little vesicles that are called platelets. Until finally, all you're left with are all these nuclei with a little bit of plasma membrane around them, which apparently the macrophages in the bone marrow love, and they just gobble them up. But your body's continually making more. Now, normally, your platelets live for 5 to 9 days. That's fairly quick. So your body is continually chugging these out, also destroyed in the liver and the spleen, much like your red blood cells would be. And much like, oh shoot, my brain just totally locked up. Low platelets, thrombocytopenia. Anemia, why can't I think? Anemia, low red blood cells, polycythemia. I'm sorry, thrombocytopenia are your low platelets. In the upper right here, this is a scanning electron microscope of some platelets spread out on a slide. Now, platelets normally aren't going to have these real spiky appendages. They're just going to be round and smooth. Whenever they become activated, they produce these little spiky appendages and they get really, really sticky. Platelets don't like to be mismanaged. They don't like to be roughed up. And so these are all activated platelets that are using these processes to stick to each other and to stick to the glass slide. And that's part of how platelets are going to function in the formation of a blood clot. So when your platelets encounter a vascular injury and they become activated and get sticky, they stick to each other, they stick to the edges of the injury, they're going to form what's referred to as the platelet plug. That is the first step in the clotting cascade. That's going to be the first thing that happens to try to minimize the loss of blood from that vascular injury. So here we have our megakaryocyte. These are some names of other precursor cells. And you can see how we're pinching off these little portions of our plasma membrane with the contents of our platelets, which are going to be critical, and we're going to see what those contents are when we get into clotting cascade. But they're very important in preventing the loss of blood. This illustration shows a peripheral blood smear on the right. You can see your donut-shaped red blood cells. And these little purplish spots that you see, you may think, well, that's just debris or garbage on the slide. Those are, in fact, your platelets. It gives you an appreciation of the scale, how much smaller they are than the red blood cells. And on the left, this is a scanning electron image showing the biconcave red blood cell and all of the activated, sticky, processed platelets are surrounding it. And when you form a platelet plug, anything that will stick to it will stick to it. Red blood cells, white blood cells, proteins, that's how sticky those platelets are. So we've got red blood cells, we've got platelets, we've got our plasma with our proteins present. We're going to utilize most, if not all, of these to try to minimize blood loss in the case of a vascular injury. So what your body homeostatically is trying to do is hemostasis, stop bleeding. And the first response to a vascular injury are going to be vascular spasms, intrinsic vasoconstriction of those smooth muscles that are around the blood vessels. If you've got a water hose that's leaking, you just pinch off the water hose. It's what's going on when you have an injury. Upstream of that injury, you're trying to pinch it off and minimize the flow of blood to minimize the loss of the blood until we can do some of the next steps in hemostasis. The next step being the formation of our platelet plug. As we looked at those illustrations of platelets, they become very spiny looking, they become very sticky looking, but I think you can imagine platelets are circulating in huge numbers in the bloodstream. You don't want platelets just to activate and start sticking to everything in your normal circulation. If they were to do that and you were to get a clot and it goes to your brain, what do you get? You get a stroke. You get a stroke. It goes to your lungs, you get an embolism. Heaven forbid you get one of these platelet clots going to your coronary arteries, then you're going to have a heart attack. If it goes into your left anterior descending coronary artery, you have an immediate massive heart attack. There's no recovery from that. They could shock you until the cows come home, but your left ventricular muscle is dead. You're a goner. So to keep platelets happy in your normal circulation, we've got some mechanisms to prevent their activation. The first are the cells that line your blood vessels. They're called endothelial cells. They're going to form a physical barrier to the underlying tissue. That underlying tissue, your connective tissue, your basement membrane, it's going to contain some materials that are very potent activators of platelets. But if you've got an intact blood vessel, intact endothelium, your platelets will never see it. So the physical barrier is one. Also, your endothelial cells, those membrane proteins on the surface that's in contact with the blood, it's going to have a net negative charge to those proteins. Well, your platelets are also going to have a membrane net negative charge. And when you have similar charges, what happens? What is our saying about charges? Opposites do what? Attract. So same charge repels. I can remember when I was a teenager, I loved to play air hockey. That little plastic thing gliding on the air, it never touched the table. Platelets are gliding through the blood and they never physically contact the endothelial cells, so they stay happy. They stay unactivated. But that's not enough. If these things inadvertently activate, it's going to ruin your day and shorten your life. So endothelial cells also produce and secrete prostacyclin and nitric oxide. Both of these, in addition to being vasodilators, are potent inhibitors of platelet activation. So you prevent the physical contact. You're sending out signals that say, don't activate, don't activate, don't activate, don't activate. We're good, we're good. And that's all produced by the endothelial cells. Is that enough? No, because it's so important not to activate them. Endothelial cells have a cell surface protein that also has enzymatic activity. That protein is called CD39. And so in the extracellular surface of the endothelial cells, CD9 converts ADP, adenosine diphosphate, into AMP. This is going to be one of those rare cases. You usually associate ADP with what? ATP. Well, in this case, we're going in the other direction. ADP is an activator of platelets. Therefore, AMP could be considered an inhibitor because it does not activate. So in this illustration, first of all, you hear me say a lot, be careful of illustrations because they're done by artists, not necessarily by scientists. Because this illustration drives me insane. Why do you think this illustration drives me insane? What do those platelets look like? They look like red blood cells. Why would you make platelets biconcave? It's just crazy. So, all right, ignore the look. Those are our smooth inactive platelets. I think it was the smooth aspect more than looking like red blood cells. Here are intact endothelial cells. We've got our prostacyclin. We've got our nitric oxide. We've also got our CD39s converting ADP to AMP. Everybody's happy. The platelets are separate from our connective tissue. No platelet activation is happening. Now, we're still good. We don't have a cut. We don't have damage. We don't have any bleeding. Endothelial cells are keeping the platelets happy. But the endothelial cells are also preparing just in case there's damage. And so endothelial cells produce and secrete a protein that is called von Willebrand's factor. Little v, big W, big F. This is produced and it's secreted not into the bloodstream, but in the opposite direction, into the basement membrane and the connective tissue. Because binding to collagens, binding to other extracellular adhesive molecules like fibronectin, while they will activate platelets, von Willebrand's factor is an even more potent activator of platelets. If you're wanting to keep platelets happy, why in the world are you making a potent activator of platelets? Well, if platelets ever see that stuff, it's under the endothelial cells. That means there's some damage somewhere, and that's when you really want the platelets to activate. How quickly do you want them to activate? Yesterday, as fast as possible. So the endothelial cells are inhibiting, but they're also preparing the extracellular environment to help activate the platelets. So we damage our endothelial cells. We've had a cut. Platelets leak out into the connective tissue. They encounter collagen. They encounter fibronectin. They especially encounter von Willebrand's factor. These molecules bind to receptors on the platelets and it activates the platelets. And these platelets, once they're activated, they have a massive release of the stored material that were in vesicles inside of all these platelets. And early histologists looking through a light microscope would see platelets and they would see all these vesicles and they say it looked granular. Well, when they would activate the platelets, all of a sudden the granules would go away because they've been secreted. And so early histologists said, oh, this is a degranulated platelet. So that's where we get this process, degranulation, meaning this very rapid secretion of all the materials inside the platelets. And the vesicles inside the platelets contain, among other things, ADP. Wait, didn't we just mention ADP? What is ADP? Activates platelets. Okay, so this sounds like a kind of feedback. ADP activates platelets. Activated platelets produce ADP. ADP activates. What kind of feedback is that? Positive feedback. Chain reaction is going to be quick and it's going to be massive. Why? Because we've got to stop bleeding. And we've got to stop bleeding as fast as possible. Thromboxane A, also activator of platelets. But thromboxane A and serotonin, in fact, are also vasoconstrictors. You're wanting to start the platelets getting sticky. You want to plug up the hole, but you also want the vessels to vasoconstrict to try to minimize the amount of blood that's even getting to the injury in an attempt to try to plug it up. You see how everything is geared to stop the loss of blood. So all of these materials, once the platelets get started because they encountered extracellular materials, everything they release is to constrict the vessels and to activate more platelets, making them sticky and have them stick all together to form the platelet plug. Now, I said platelets are sticky. They don't just stick to each other. They stick to red blood cells, they stick to white blood cells, and they stick to plasma proteins, including our clotting factors, fibrinogen. Fibrinogen is the inactive form of this filamentous protein that's going to form our clot. And by binding to fibrinogen and sequestering it at the platelet plug, you've got the building block in place, once it's activated, to start forming this spider web that's going to, in fact, be our blood clot. So you're plugging the hole with platelets, but you're also causing a lot of the clotting factors to be sequestered in place that's going to help us with the next step in forming our blood clot. Here's our activated illustration. And again, they're trying to make the platelets sort of spiny looking. But again, these others still look like red blood cells. You can see we've damaged our endothelium. Our platelets are encountering our collagens, our blue von Willebrand's factors. So that activate, there's a thromboxane, ADP. We don't see serotonin, but that's another one of them. ADP is also in there. And here we're trying to illustrate the clotting together, the binding together of the platelets to form the plug. Now, this illustration also makes me crazy because what do you make of these brown threads in here? It looks like the collagen. No, they're trying to illustrate the fibrinogen, but they made it look like the collagen. So that's just to illustrate that you also have those clotting factors like fibrinogen binding in here to the platelet plug so that we can now do the next step. That next step being forming a blood clot. I think that's enough for today. Blood clot's going to be a big one, and we will wait